So thank you very much. Thank you for the scientific committee who are inviting me this morning. Do you see my screen? Not yet.
Yes, now we see it.
Perfect. So yes, I'm very sorry not to be present with you in person today because my plans were unexpectedly affected by the airport strikes in Belgium. So nevertheless, I am excited to discuss with you the potential impact of adenomyosis and endometriosis on implantation with you. As we explore the key factor influencing human implantation, it's essential to recognize that success relies on the intricate interplay of several biological mechanisms. First, endometrial receptivity plays a critical role. During the implantation window, endometrium undergoes molecular and structural changes and the appearance of pinopode, making it receptive to the blastocyst. Additionally, hormonal synchronization between progesterone and estrogen is crucial. These hormones not only prepare the endometrium, but also trigger stromal cell differentiation into decidual cells. Embryo quality is another significant factor. Chromosomally normal blastocyst has a greater chance of implantation success, with metabolic and epigenetic profiles playing a role in this potential. The embryo-maternal interaction is also a key, mediated by cytokines, growth factors, and adhesion molecules, which ensure proper trophoblast invasion and attachment of the blastocyst. Lastly, the human environment must be finally regulated. Uterine NK cells, regulatory T cells, and macrophages create a delicate balance, and any immune dysregulation or excessive inflammation can result in implantations failure or early pregnancy loss. And understanding and optimizing these factors are crucial for improving implantation success, especially in assisted reproductive technologies. And this slide illustrates the cellular dynamics occurring in the endometrium before and during embryo implantation. Prior to ovulation, estradiol drives rapid endometrial growth influenced by morphogen and cytokine gradients. And this results in diverse cell population, including exhausted, stressed, and non-stressed cells, alongside the emergence of ciliated epithelial cells. And after ovulation, progesterone induces changes such as the formation of glandular vacuoles, a decidual reaction, and the recruitment of UNK cells and MSC cells during the implantation window. So after the implantation, some pre-decidual cells became senescent, initiating an inflammatory response that is counterbalanced by UNK cells, which remove the stressed cells. And these processes highlight the hormonal and cellular choreography that underpins successful implantation. And this one illustrates the molecular signaling networks complementing the cellular changes during the implantation window and decidualization. Hormonal signals like progesterone and estrogen regulate uterine receptivity through interactions between the blastocyst and the luminal epithelium. And these pathways drive key changes like glandular vacuoles, the decidual reaction, and the accumulation of UNK and MSC cells. And here is highlighting the molecular networks in decidualization where stromal cells differentiate to support the embryo. And this regulation of, for example, OXA10, a key gene for stromal differentiation, can impair this process, especially in conditions like adenomyosis and endometriosis. And we know that human reproduction is often described as inefficient, as we can see here, with only 40 to 60% of conceptions resulting in live births among young and healthy women. A significant portion of pregnancy losses occurs so early that they go unnoticed, having minimal impact on a woman's reproductive health, while increasing the likelihood of the future conception. And the remaining losses manifest as clinical miscarriages, 90 to 95% of which happen within the first 12 weeks of pregnancy, as you know. And given that conception rates per cycle are below 40%, pre-implantation embryo loss rates of 20 to 40% are considered within the normal range. And implantation failure can be linked to issues related to the mother, the father, the embryo, or a combination of all three, highlighting the complexity of the condition and the need for a comprehensive evaluation of these cases. And the study by Paul Pichea revealed that true recurrent implantation failure, or RIF, is relatively rare for patients capable of producing euploid blastocyst. Less than 5% failed to achieve the clinical pregnancy after the transfer of 3 embryos. And this suggests that RIF is less common than often perceived. And according to the latest ESHRE recommendation of 2023, a cumulative predicted implantation chance of over 60% should trigger further investigation into RIF. However, the number of failed transfers considered should be adjusted based on the patient's age and the number of embryos transferred, including those with confirmed euploid by PGTA. And the threshold helps identify clinical RIF, indicating the need for additional diagnostic or therapeutic steps to enhance pregnancy success. And the normal chromosomal constitution by PGTA is the strongest predictor of implantation success, yet its predictive value is limited as 50 to 60%, as we show, revealing that it's the black box of implantation, and factors like low blastocyst quality, maternal age, obesity, and RIF can reduce live birth rates per euploid blastocyst transfer. And Professor Somigliana's table, published in 2018, outlines various factors that can impact the endometrial receptivity and contribute to RIF. And among these factors, adenomyosis and endometriosis are included, but their roles in implantation success remained debated. As you know, endometriosis is a very common chronic inflammatory disorder affecting about 6 to 10% of reproductive age women, or approximately 200 million women worldwide. Also, accurate statistics are sometimes difficult to obtain. It's estimated that 25 to 50% of patients undergoing fertility treatments have had endometriosis, and that 10% of the indications for IVF is represented by endometriosis. And several factors observed in patients with endometriosis will influence the fertility, including dyspareunia, mechanical factor, ovarian reserve, impaired ovulation, and endometrial receptivity. Some data suggest that endometriosis can also adversely affect oocyte quality, leading to structural abnormalities such as cortical granule loss, spindle disruption, and zona pellucida hardening. Additionally, endometriosis is associated with decreased mitochondrial content and dysregulated molecular pathways in oocytes, further compromising their quality. Nevertheless, in this recent meta-analysis published this year by Sonia Gayet-Lafuente, it seems that these observations on oocyte quality do not impact the fertilization and the blastulation rates. However, fewer total and metaphase 2 oocytes were retrieved in patients with endometrioma, and the number of top quality embryos is also reduced. And we know that endometriosis involves inflammatory cytokines like interleukin-1 and 17, but also TNF-alpha, which can increase COX-2 and PGE2 and aromatase expression. And this triggers the STAT3 activation, stabilize F1 alpha, and leads to a pro-oestrogenic environment with progesterone resistance. And this is also linked to a OXA10 dysregulation, as we have discussed earlier. And it may also shift macrophages to a pro-inflammatory M1 state and affect dendritic and Treg cells, contributing to implantation difficulties. It can also alter the key receptor levels that will further impair the implantation in endometriosis. But in the study by Bishop in 2021, we can see that he explored whether endometriosis-related subfertility is linked to impaired endometrial receptivity by comparing 459 euploid frozen embryo transfer cycles with two control groups, the non-infertile patient with PGTM for single gene disorders and couples with male factor infertility. And this study found no significant differences in clinical pregnancy rates, pregnancy losses, or live birth rates between endometriosis patients and control. And euploidy rates were similar, suggesting that endometriosis may not impact IVF outcome through endometriomal receptivity, but leaving its effect on oocyte quality or the endometrium unclear. To further explore outcomes related to embryo transfer in endometriosis, Chang conducted this systematic review and meta-analysis. He analyzed 6 studies, but with moderate methodologically quality, but including more than 3,000 women with endometriosis. And among them, 59% underwent frozen embryo transfer, while 41% had fresh embryo transfer. And the analysis showed that frozen embryo transfer resulted in a significantly higher live birth rate and a lower miscarriage rate so the clinical pregnancy rates were similar. And these findings suggest frozen embryo transfer may provide better outcomes for endometriosis patients, but further high-quality research is still needed. And now we can move on to adenomyosis, a condition where endometrial tissue is found within the myometrium, surrounded by hypertrophic muscle cells. While it shares similarity with endometriosis, the adenomyosis is more common in women who have given birth and may result from the repeated damage to the endometrial myometrial junction due to pregnancy or heavy menstruation. And advances in imaging have increased diagnosis in younger women with prevalence rates between 5 and 50%. It coexists with endometriosis in 70% of cases and is found in 20 to 35% of women with abnormal uterine bleeding. Adenomyosis impairs fertility through several mechanisms. Anatomical changes like enlarged uterus or intramural adenomyomas can disrupt sperm migration, embryo transfer, and implantation. Second junctional zone, so GZ, is linked to impaired implantation failure. Hormonal imbalances such as abnormal estrogen receptor expression and progesterone resistance also along with the pro-inflammatory cytokines and uterine NK cells dysfunction further reduce the implantation rates, contributing to fertility issues in women with adenomyosis. And is that what we can see here in this meta-analysis published by Younes and Tulandi in 2017, reviewed 11 studies comparing IVF outcome in 519 women with adenomyosis and more than 1,500 women without the condition. Here we can see 4 studies that were used to evaluate the implantation rate, and the findings revealed a significantly reduced implantation rate in women with adenomyosis compared to those without. And this was not confirmed in this prospective study published this year by Mauro Cozzolino. However, in this case, the patients were all recipients of egg donation, unlike the meta-analysis by Younes and Tulandi. And let's return to this meta-analysis. Here we can see 8 studies that were analyzed for the clinical pregnancy rate, and we can see that this rate is also significantly lower in patients with adenomyosis. All the patients here were transferred with embryo from their own oocytes, except the study of Martinez and Conegero. And this lower clinical pregnancy rate was confirmed by a retrospective study published in 2023. The study analyzed more than 3,000 patients undergoing their first blastocyst frozen transfer in an hormonal replacement cycle, including 140 women with adenomyosis diagnosed using solid ultrasonographic MUSA criteria, which is important. Adenomyosis patients were more likely to have deferred frozen embryo cycles and pre-treatment with GnRH agonist. And the presence of adenomyosis significantly reduced clinical pregnancy rates in this study. Again, this finding was not confirmed in the prospective study by Mauro Cozzolino, which focused solely on patients undergoing egg donation. Now let's take a look at the risk of miscarriage. An increased risk of miscarriage in adenomyosis patients was confirmed in the meta-analysis, and this is also confirmed in the retrospective study. And this time, it is also confirmed in the prospective study by Mauro Cozzolino, so the higher risk of miscarriages in patients with adenomyosis. And it is also important to consider the type of adenomyosis as highlighted in the Cozzolino study. Specifically, when adenomyosis was detected in the GZ through transvaginal sonography, there was a more than 3-fold increase in the relative risk of miscarriage. Conversely, adenomyosis confined in the outer myometrium was associated with a higher ongoing pregnancy rate. Furthermore, diffuse adenomyosis, adenomyosis in the GZ and severe adenomyosis doubled the risk, the relative risk of miscarriage. And the importance of adenomyosis type is further emphasized here in the Han study published in 2023. This research examined the effects of different types of adenomyosis on IVF outcomes using the ultra-long GnRH agonist protocol. And the findings revealed that diffuse adenomyosis was associated with significantly lower clinical pregnancy and live birth rates, as well as a higher risk of miscarriage compared to focal adenomyosis or tubal infertility. Following this, Wang's study from 2023 sheds light on the growing prevalence of adenomyosis among infertile women and its impact on IVF outcomes, particularly when diagnosed with ultrasound. And this meta-analysis found that women with ultrasound diagnosed adenomyosis had significantly lower live birth and clinical pregnancy rates, along with a higher risk of miscarriage compared to those without adenomyosis. Diffuse and symptomatic adenomyosis were especially detrimental to IVF outcomes, while asymptomatic adenomyosis had lesser effects. And additionally, concurrent adenomyosis and endometriosis were associated with worse IVF outcomes than endometriosis alone. However, the study highlights the limited number of studies using standardized MUSA criteria in the analysis. And just before to conclude, I want also to show you that adenomyosis and endometriosis not only affect fertility, but also have a significant implication for obstetric outcomes. It can increase the risk of complications such as preeclampsia, preterm birth, and restricted fetal growth by disrupting early pregnancy events and impacting the entire pregnancy. And just to finish, here is my conclusion slide. So endometriosis is associated with a lower number of metaphase 2 oocytes and top quality embryos. No significant impairment in implantation rates, but there is an increased risk of miscarriage, and it seems that it's particularly with the fresh transfers compared to frozen. Adenomyosis is linked to lower implantation and clinical pregnancy rates through no significant when donor oocytes are used. There is a notably increased miscarriage rate, especially in cases of diffuse or severe adenomyosis. However, there is still a need for more well-conducted prospective study with strict criteria, particularly regarding the patient inclusion, symptomatic versus not symptomatic, but also the ultrasound evaluation of the adenomyosis that must be standardized. So thank you for your attention.